Thank you very much for this nice introduction. I will try to express the prolonged release protocols in clinical practice, which may help the audience more than the scientific part to use in the clinical practice, and insights from the Turkish transplant centers, which we don't have any metabolic investigations, but we know how to use it. So I'll tell you what we did in Turkey. Today, my objectives are understand the role of Advagraph, which is a prolonged release tacrolimus, review its clinical use in liver transplantation, evaluate supporting clinical trial evidence, discuss dosing, safety, and monitoring, review the use of prolonged release tacrolimus in Turkey, share practical outcomes and challenges in our country, and highlight real-world clinical experience. So we all know what's Advagraph. Is an extended release tacrolimus. Some of the slides can be duplicated by Professor Kim, but maybe it's better to understand for everybody. It's a calcineurin inhibitor. It inhibits interleukin-2 and T-cell activation, which most of the world now uses for the preventing the rejection. It's not bioequivalent to immediate release tacrolimus. We have this mistake all the time that we think they are the same dose when you convert from one to another, but they are not. And better adherence and tolerability are the key advantages, because adherence is very important to prevent the rejection. So its pharmacokinetics was discussed before me, and it has a slower absorption, which means a longer Tmax, which means less toxicity actually, lower peak concentrations. That's good that you can have a longer time with the same level, but you have to be careful with the dosing because you can create rejections even in the late periods. So less flatter, it is flattering during level profile and less variability than twice daily tacrolimus. These are the advantages. And the indications are it's approved for rejection prophylaxis. So you can start from the beginning of the transplantation, which most of us, including me, don't use it like the first month. But there are studies starting in the first month, which has the good results, which I'll show you now. You can use de novo, as I told, or convert from immediate release, which most of us do converting. Usually when you want to prevent rejection at the early period, you combine with MMF, steroids, or basiliximab. So it has the equivalent rejection rate with tacrolimus and immediate release tacrolimus. It has a better long-term adherence. And if you convert, the successful conversion is preferred in stable patients, safe and effective daily regimen. So if you want to convert it, the patient should be stabilized after a week, after a month, after long term. But the patient should be stabilized before converting. So think about that before this. Adverse effects are nearly the same with the immediate release tacrolimus. They, as you all know, include nephrotoxicity, neurotoxicity like tremors, basically headaches. It can have hypertension, hyperglycemia. It can have gastrointestinal problems. They have any kind of complication related with neurotoxicity. You can see people change behaviors. You can have any kind of complication. If you are using a tacrolimus, you have to think about this, even immediate release or prolonged release. So any kind of neurotoxicity, you should first of all think it can be tacrolimus, then you can think the other complications. So as a lower Cmax with the prolonged release, it has less toxicity, especially in the older ones, because we can see the tremors as the aging comes. So in older patients, the neurotoxicity is less, so you can maybe more safely use the single dose or prolonged release tacrolimus in this group of patients. The second thing is the adherence. It's also useful for the oldies to be adherent to the drugs, because if you are not adherent, if you are not using your drug properly, it opens the rejection. And when the time passes, the patients don't want to be controlled as it's recommended. So longer the period from the transplantation, the more non-adherence to the drugs, that they do not use their drugs. So you have to be careful about the longer term results of the drugs. you have to avoid CYP3A4 inhibitors or inducers. You know what they are, especially which we use every day is a grapefruit juice is an inhibitor, and it can increase the levels of tacrolimus. So when we give any kind of tacrolimus, we have to think about the medicines that should not be combined with this, like the chloromycin, ketoconazole, which we use in most of the patients. So you have to be very careful if there's an inhibitor or inducer, so that changes the level of the drug. So in diabetics and renal dysfunction, you have to be very careful with the dosing. It has a clinical benefit in selected populations, especially for chronically ill, and the low Cmax, as I told you, can decrease the neurotoxicity. So why it doesn't move? Okay, why prolonged release? As I told you, okay, this is one study coming from ELTR. This ELTR study shows if you start the prolonged release tacrolimus in 1 month versus immediate release tacrolimus and follow up for 3 years, it shows that a little bit advantage in patient survival and graft survival. So you can easily use when you stabilize the patient in 1 month. This is basically cadaveric organs, disease organ transplants. It's having a very few living donors. It's mostly disease donors. So it might be different in both ways. So looking at the ELTR data, which has a lot of patients actually, and more than 500, so the results are good for the benefit of the prolonged release. So as I want to control, the control of the monitoring of the drug level is very important if you convert the tacrolimus from immediate release to prolonged release. And variability in insurance reimbursement is important because in Turkey, the first 5 years of Advagraf, which is a prolonged tacrolimus, is not paid by the government. So you have to pay for it. So in many countries, there is variabilities in insurance reimbursement. So we are using Advagraf more often in the last 5 years. It's been in the market more than 10 years, but we are using in the last 5 years more than normal. So cost concerns in many public hospitals in the world, I know that. So as a summary, before I'm coming to Turkish data, safe, effective in adult liver transplantation, equal efficacy with immediate release tacrolimus. I'm saying safe, effective in adult liver transplantation. The pediatric group is not accepted for FDA now, but we have some data, especially from Korea data, that you can use it safely. But the absorption is different in pediatric group. The metabolism is different in pediatric group, especially in small children. You have to be very careful if you want to use this drug. So we prefer using immediate release tacrolimus in the pediatric group. We usually don't use, if there's a very special need for Advagraf, we use standard tacrolimus BID in the pediatric group. You can use it, but you have to be very careful while using it. So I'm coming to Turkish clinical experience. I want to talk a little bit about Turkish transplant units because we have one of the most number of transplant units per million in the world. So we have per day 51 liver transplant units, and it's the highest number of liver transplant units per million in the world. And looking at the numbers, what we are doing about 1,700 liver transplants per year in the last 5 years. I'm not taking the periods before that, but it's slightly increased and stabilized around 1,600 to 1,700 in the last 5 years. And looking at the DDLT versus LDLT, around 80-85% is LDLT and only the 15% is DDLT. So our DDLT numbers are stabilized in the 10 years, around 150 and 200. But the number of LDLT is getting more and more every year. So usage of the immunosuppressive drugs, looking at them, 90% of our liver transplant patients in Turkey are using tacrolimus-based immunosuppression. So only 10% are not using tacrolimus, either using cyclosporin or not using any other calcineurin inhibitor. And looking at the numbers of the prograph versus advagraph in this 90%, only 10% of the patients all over the country are using advagraph. So it's less, but when you look at the numbers, why we using 10%, we have no country data. So we don't have any data. All these data are our data or added by the personal communication. Looking at what we have done in the last 8 years with more personal communication, total number of liver transplant patients which are converted to advagraph is 895. And the follow-up. But total patients that's converted is 87. So 895 patients in 2 centers which have been done. I'm taking the last 8 years because we were not using advagraph beforehand. So the last 8 years, out of 895 patients, only 87 used to convert it to advagraph. So it's the 10% like the whole country. Mean age was 55, mean weight was 76. Mean time from transplant switch was 28 months. That shows that we and none of the country transplant units converts before 2-3 months. Basically, the mean time for is 28 months. Nobody starts as a de novo transplant preventing rejection medicine to advagraph, but usually uses to convert in the later period. When you look at the underlying disease in this 87 patients, HBV is still the most common disease in Turkey for liver transplantation. And reasons for switch is a couple of reasons. We had elevated creatinine dose reduction, which might induce rejection if you don't control the dose routinely, maybe more often than the time being that you have to look for the dose levels in the stable patients. Very low tacrolimus requirements, wanted them to be only 1 drug a day. Simplification to once daily dosing in 51 patients. It's not, there's no study like that. So people, you can understand from the clinical bias that they are not adherent to the drugs. They always ask you when to stop the drugs, when to stop the drugs. It's a good step forward, at least to reduce the number of drugs that they are using so they can adhere the drugs that you give for preventing the rejection and you can have less toxicity. In this group, rejection episodes was in 12 patients, which is not very few because they are all stable and long-term patients. And when we change for creatinine, we can see in some of them rise in the creatinine levels. So you have to be very careful while we are changing it for creatinine or for adherence. In follow-up, you can see some rejection episodes in 12 patients and 2 had to be reverted to prograph. I want to say that the rejection episodes are not biopsy proven. They are clinically expected and they are clinically manipulated in our center or in different centers. So we can say all data in Turkey, we can find out. We have a comparable rejection and graft survival rates between the immediate release and prolonged release. Positive feedback on adherence, they love to use only 1 dose of medicine a day. Some improvement in neurotoxicity complaints, especially in the older guys, and limited long-term data, unfortunately, in this local population. So what we should look for the future, we need a national data registry. We needed to standardize the protocols and monitor outcomes to be sure and to tell better things to the community. And standardization of progress across centers makes it better for the future usage of this prolonged release tacrolimus. As a conclusion, prolonged release tacrolimus is well tolerated and I cannot say widely, but it's used in Turkey and effective. Real life use in Turkey reflects global experience because when we look at the global data, it's nearly the same. And further harmonization and outcome tracking and more data is needed to talk more precious on this single daily dose tacrolimus. Thank you very much.